I start my talk with hemorrhoidectomy. Why the hemorrhoidectomy is needed for us? So I start with a question. You can see a picture. There is a prolapsed mass, 60-year-old gentleman, presented with complaints of mass descending per rectum and intermittent painless bleeding per rectum for 2 months and severe pain. So patient immediately presented to OPD after severe pain and prolapsed mass of 4 to 5 days. What is your plan of approach for this case? So, Jitin is telling about Chivitis hemorrhoidopexy.
This is a internal external hemorrhoid with external
internal
edema.
Correct.
Any procedure that will take later, first Hylase has to be injected so that edema should reduce, or at least glycerin mixed with antibiotic with seeds bath for 48 hours to be given so that external edema should reduce, and then you can plan according to the stage and complications if they are. Maybe Chivte, maybe MIPH, maybe MM.
Any other opinions in the hall? Pain is because it is external-internal. Definitely there is an external bulge, so there will be definitely pain. So first line of our approach should be to reduce the pain. So now the question is the patient is ready for the surgery? Sometimes at around 60 years, majority of the patients on antiplatelets, lot of other comorbid conditions. If patient is ready, then what is the approach? If patient is not ready, whatever the Kodwanis are told, give the injection Hylase at the OPD itself, wait for 10 to 15 minutes with the gentle compression and slowly with the xylocaine jelly, try to reduce the pile masses inside. Maybe it cannot go inside totally at a single go, but after 3 to 4 hours, again you go and do the procedure with compressive dressing at that point. So definitely patient will improve with pain and other symptoms. Is the surgeon is ready to approach that case? Long back when I was in post-graduation, glycerol maxil, foot end elevation, wait for 3 days, giving antibiotics, wait to reduce the edema and all, then only go for the surgery. That was the old teaching. Still in the government medical colleges and all other medical colleges, senior surgeons used to tell the same thing, because the proctology is a different subject. It is evolving slowly and it is gaining rapid importance in the society because the burden is more. So we have to avoid readmissions. Whenever patient is coming to us, if it is needed, you have to approach and you have to resolve the patient problem in a single admission itself. Try to do in a single go. If the surgeon is junior, not able to do the procedure, then take some senior help. It is nothing wrong. You can see this case of 54-year-old lady presented with history of constipation, chronic constipation. That is the cause for that prolapsing hemorrhoids at the area. And intermittent bleeding, and after 54 years of that problem, patient has come to our OPD. This is the picture. On table, this is the picture. Can you see that 3-7-11 o'clock hemorrhoids? 3-7-11. Other than that, any other hemorrhoids, can you able to make it out? So secondary hemorrhoids are also there. So now again we have to think on table also. If only primary hemorrhoids are there, how to approach, and secondary hemorrhoids are there, what is our plan of approach? Definitely it will be changed. And you can see this case of hemorrhoids. This is also on table before surgery. You can see some gangrenous patches, necrotic patches, thrombosed, hard prolapsed piles. In this case, how to approach? Definitely injection Hylase will help to reduce that thrombosis. It melts that and it can give the way to proceed with the surgery. So in these cases, another case you can see, this is a 74-year-old patient with mass prolapsing. In this case, what you will do? There is not only 3-7-11, there are multiple hemorrhoids are there. So how to manage? All these are there in our mind when we see on table the patients like this. So maybe we think the plan is different prior to the OT, and on table your plan should change. So always you have to counsel the patient about the changing of the pattern of the surgery also. And types of hemorrhoids we know internal, external and interno-external, and the position we know standard classical 3-7-11. Why they are not deviating that, even though the internal the hemorrhoid arteriovenous cushions, why they are placing at 3-7-11? Number of times callots is having lot of deviations, other anomalies are lot of anomalies are there, a lot of other anatomical deviations are there, but particularly in the anus it is standard 3-7-11 we see, because now only just I discussed with Madhvi madam, she told maybe the tinea are the causes, they are coming and staying at that position sending, so maybe that is the cause. And what are the secondary causes? If secondary causes are there, is your approach is changing or not? We have to think about it. And the pathophysiology I already told, mainly deterioration of the connective tissue, cushion hypertension and sphincter hypertonicity. And the Gallagher classification standard 4 degrees we know, and in the 4th degree there is again ABCD depending on the single or reducible or irreducible, only primary or along with the secondary, that is 4ABCD. Depending on that our plan of action should change definitely. So the last one, the Gallagher classification we know 1, 2, 3, 4, but we are not concentrating on 4ABCD. And this is the latest classification. You can see that 1919 Miles started the classifying the hemorrhoids. That was in 1919. So now we are in 2022. That is the latest classification of the hemorrhoids. It's being changing because it is not a constant disease. It is not a disease at all. It is a physiological problem of the mankind because of our lifestyle and all. So the last latest classification is patient reported outcome measure hemorrhoidal impact and satisfaction score. This is from HISS. Okay, then I go to my surgery itself first. This is the 3-7-11 o'clock Milligan-Morgan. We know that the Milligan-Morgan still holds the gold standard. Its seat is still it is gold standard, because whenever it is unable to do any other procedure, this is the only procedure we can give 100% good result if you follow the principles properly. So always it is a V cut at the anodum, near to the anodum, and whether you are using the energy source or otherwise you are using a manual pedicle, it is nothing matters, but be sure that the intermittent skin you are preserving, and always it should looks like a clove. If that is a clove, your life is happy. If it is dahlia, the problem is patient will see you recurrently. So you can, now we are using lot of energy sources, that is biclamp ligosure. You can use monopolar, bipolar, everything in precise way. But taking of that anal skin marking is important. Don't think of taking marker and this you can see, this is the manual ligation what I am showing. Always I take a base ligation, first pedicle base ligation. By that the hemorrhoidal mass also will be supple and easy to handle. So take 2 stitches of the base of the pedicle, then you come to anodum. This is the where I am making a V cut and taking the skin. This is the base and that is the slowly I am going inside by lifting the pedicle submucosally, because we know that the disease is only submucosal. It is not up to the muscular plane. and lift it, and then you can go there. And in the third video you can see that just at the edge you are removing it. Your suture, after taking at the base, you can ligate both the edges also.
So important thing is we have to take out hold the cushions, and the sphincter should be low down.
Yeah,
It should be
the
separated
muscle.
from the sphincter.
Yeah.
That is the important thing.
Sphincter should not be involved in any ligature. So there are number of variations are there in Milligan-Morgan, and majority of the times we come across along with the fissure also with the piles. So if fissure is there, what to do? This is the balance operation. It is there in the literature. After removing of the 3 cushions, we have to put a advancement flap at the fissure area. By that the patient will be lot of pain relief will be there. This is the semi open pedicular hemorrhoidectomy of the parts. You can see that both the edges after the base we can see this is the ligature, and that is the semi open. By that the discharges or anything is there, it will be let out and the patient won't have any pain. And Whitehead technique, it was actually Whitehead technique. When I started, I used to do this. It is very nice technique if we do properly, because lot of times we come across lot of prolapse from the anal canal. So there are number of variations in that, and complications of hemorrhoidectomy that we have to know. This is the score of Milligan-Morgan and Ferguson. Ferguson is almost a failure, but because on table we feel that we have done a wonderful job. But after that, because of the sutures, patient will have lot of pain, and the suture adhesions, at any cost the sutures will be given away, and other wound infections will be more. So try to be more open at the perineum. It closes immediately because of the vascularity. And this is the stenosis, and these are the majority of the areas, stenosis and hypertonicity, because of the sphincter spasm after the surgery. So try to avoid it, and more complications are seeing at 60 to 70 years of age. And role of internal sphincterotomy along with the hemorrhoidectomy. This is the question, whether you will like to do the sphincterotomy with the hemorrhoids or not. If you want to do the sphincterotomy, definitely I feel in my practice, not the literature also I quoted, at the young age, before 50, it gives good relief. After the surgery, patient will have comfortable feel to pass the stool. But after 60, 70, don't go and don't do the sphincterotomies, because already the sphincter is lax. And one thing, only one message from my side is, one size does not fit all. The best intervention has to be individualized depending on the patient's need and your examination and history. Thank you.
How many of us are doing this
And
Milligan-Morgan?
one more thing, sir, Botox injection. I regularly gives Botox. It is usually there are no side effects and no complications. I observed till now almost 300 to 400 I have done since almost 2014. And there is a vacuum bottle will be there. You are injecting the fluid whatever they have given. Through that vacuum, once you inject, there won't be any drug. When I started, I wondered, there is no drug in the bottle. It is totally empty. You have to inject, then you take it, give all the 4 quadrants, and usually I give at the fissure area also. Within 24 to 36 hours, the patient will have pain relief wonderfully. But the recurrences are very high. Usually we have to tell them it is a bridging technique before sphincterotomy. And one more thing actually, yes.
You have covered everything.
No need. That's what I am telling. No need. Only the history is enough. That is enough.
So many of us are doing Milligan-Morgan. How many are doing Milligan-Morgan? Everybody? Everybody. So you know that Milligan-Morgan gives a lot of pain. Is it right? Post-operative pain really. So there is a massive pain in this post-operative pain in Milligan-Morgan. It may be Ferguson or it may be Milligan-Morgan. And hence I was talking when I started my first initiation that we are having all painful proctology. So we have to go from painful proctology to painless proctology. So the newer procedures will be told us now. We have to learn, we should know Milligan-Morgan, but now newer procedures are there. We have to learn that, and that will give you, that will enhance your competence and your confidence also, and your practice also as well. So let us know, because this association was formed with the innovation of Dr. Chiute, that one should concentrate on painless proctology. So we will now move from the painful proctology to painless proctology. The next lectures will be followed. Please.
Madam,
Hello. It's a nice talk, Shanti.
You see that?
Madam, okay,
Sir.
okay.
Yes. Yes, yeah, circumferential hemorrhoids are there, then better not to go for the Milligan-Morgan. Try for other measures, and Chivate's procedure is one of the best procedure. Yes, sir.
Madam, a few highlights about the Hylase injection.
Yes.
How much, what is the dose, what is the method to give, how to give? Thank you.
Kadwani sir.
Better please enlighten.
So, sir, 2 ml of powder will be there in the hyaluronidase vial. In that we have to add 2 ml of the distilled water. Each vial contains powder of around 1 ml. In that you are adding 2 ml. With that, I usually make 5 ml of that vial with the distilled water. That 5 ml I give at the base, at the outer anoderm, and if the pedicle is here like this, at the lateral aspects and at the base, and actually subcutaneously into the pile mass, sir. Then compress, wait for 3 to 5 minutes. Each pile mass, it takes time.
That is practiced only in a thrombose or edematous or painful hemorrhoids,
Yes,
prolapsed.
only thrombosed edematous when they are not able to reduce properly. Otherwise, there is no need. If you want to go with the surgery, then if there is no way inside to keep the proctoscope also sometimes, then it helps a lot.
Thank you. One comment about the seniors or what he said. I come from a semi-peripheral areas. No surgeon should feel embarrassed about doing a Milligan-Morgan's. That is the gold standard of the proctology work. Even still today, after 30 years of my active surgical works, I am yet to take up the orbital delegation or laser or whatever it is. Even today, my maximum number of surgeries, bottom hemorrhoids are concerned. It is Milligan-Morgan's hemorrhoidectomy.
Yeah.
Everybody should master it. Of course, we need to upgrade, we need to improve ourselves. So don't have to feel, because every conference I attend, somehow always you feel, oh, I am doing outdated, I am an outdated surgeon. No, nothing.
No, sir,
But
we
second
told
thing is,
Milligan-Morgan is the gold standard.
it is gold standard. Remember, no recurrence, patient is totally satisfied. Pain will be there. I do agree, as sir said, pain is there. There are many methods to overcome the pain, etc. Other things are there. So one need to master the Milligan this technique. Second thing is, as you said, madam, sphincterotomy in a younger age group will definitely help. In my days, our professor used to do a anal dilatation before doing a hemorrhoidectomy. Before doing a hemorrhoidectomy, always used to combine it with a MAD, that's
Yes,
manual,
sir.
and
Yes,
then
sir.
go for a hemorrhoid. That
Yeah,
is
that's
really
why I
pain.
told 50 years, at least just
Yeah,
for
after 60,
common-
tone is less and no
Yeah,
need.
so
Thank
that's
you,
why
thank
there
you.
is not. Okay.
Sir, it is always Milligan-Morgan office procedures, they need to be mastered, because when prolapsed hemorrhoid come, it will not go with laser, it will not go with stapler. Alone stapler, laser, whichever procedure you do, it will be inferior. You have to combine it with Milligan-Morgan, you have to combine it with banding, you have to combine it with sclero, then only it will give a result.
Yeah, and one
So
more thing, it
you
is
should
only,
know to perform all these procedures.
it is only benign disease, there is no need of any radicality. 100% decrease on table, there is no need.
One thing, when we are talking about Milligan-Morgan, which I did for last 5-6 years, I did earlier, but from last 12 years, I have not done a single Milligan-Morgan. That is the story. So every day, even if one or two hemorrhoids we are operating, I have not touched Milligan Morgan for last 12 years. Last 12 years, even prolapse, thrombose, hemorrhoids patient is there, I don't do Milligan Morgan. Why so? Because whenever the circumferential hemorrhoids are there, and if you are to do the Milligan Morgan, there has to be renal stricture. There has to be renal stricture. If you remove the circumferential hemorrhoid in a prolapsed thrombosed hemorrhoidal case, there will be stricture. So if this has to be avoided, the new procedures, tooth procedure has to be learnt very keenly. I tell you, once you master that tooth procedure, you can do even complicated hemorrhoids also. Even that madam had said that even the literature says that the injection highlights to be injected for having removal of the thrombose or to absorb the thrombose. I never do it. Why so? Just whatever the thrombosed and the necrosed part of the hemorrhoid is there in front of you, you just push everything inside. Push everything inside. Try to push everything inside with lignocaine jelly, head low position, very slowly you have to pressurize. And you put the things, everything inside. Ask the patient to remain on the bed for 6 to 8 hours and take the patient for the surgery. What will happen? When the prolapsing mass goes inside, edema regresses automatically. Why so? Because the resting tone which is there causing the obstruction, once you push the pile mass inside, the edema will regress after 6 to 8 hours. And now when you take the patient for hemorrhoidectomy or for any of the procedure, you bring it out. That time only the necrosed part is there which is seen in front of you. So that part is to be removed only. Cut it with any knife, remove that thrombosis, push it inside and then carry out any of the procedure. So what I used to do previously, Milligan Morgan for this prolapse and this. So because the result was very, very bad, because the result was anal stricture. Then anal stricture, one has to do dilatation, then mucous advancement flap, then other flap procedure. So we will be having the detailed discussion about the complications of hemorrhoid. That will be now in the next few of these. In the next session, there will be a symposium on that. Then we will come to know what are the complications of hemorrhoid surgery. So yes, you should master the Milligan Morgan, but the new procedure has to be learned, because once you master the new procedure, you will definitely, I tell you, you will forget Milligan Morgan.
Sir, Ladukar sir, here I beg to differ with you that Milligan Morgan you have not done since 12 years. The only thing, whenever there is grade 4 complicated hemorrhoid, there is thrombosed hemorrhoids or necrosed part is there, you have to excise it. Number one. So once you excise it and do the test, that becomes a hybrid itself. Number one. Number two. What it looks grade 4 on table on your first examination because of external edema, what Dr. Shanti has shown, if you give Hyles, who knows, it turns to be grade 3. See, I make you a remembrance. In case of any CA breast or any other CA, what the people are doing before surgery, they are giving chemotherapy just to downstage the staging so that surgery becomes easy. The same thing for the grade 4, what Dr. Shanti has shown, go for Hyles first. In 15-20 minutes you will get the result. Who knows, the grade 4 turns out to be grade 3 and the test will give the better results. Thank you.
Thank you.
Good talk, Dr. Shanti. See, I also second my thought of what Dr. Ladukar said. In my practice also, I have reduced Milligan Morgan to almost minimal. I only do only for the external hemorrhoids associated with internal hemorrhoids and thrombosed hemorrhoids. Only those cases. Rest I do by test. Because in this we are removing anal cushions as if there is no role. Whereas Dr. Ganga has told that 20% of continence is maintained by anal cushions.
There is no need.
So we have, although labeled it as a gold standard, I am sure once you learn the test, and Dr. Vikas will tell, the gold standard has yet to come, and that Dr. Vikas is going to tell that.
Good evening, ma'am. Actually, injection Hines, actually we used to do for only skin tags, ma'am. Skin tags? Skin tags we will inject injection hyaluronidase injection, and it will, immediately it will shrink in the post-operative day.
I I never used like that. I'll see once I go there.
If
because-
you use in the
Okay.
skin tags, we
Usually
can
skin tags we are excising
we
with a
excising,
sharp.
but without exercising, if you do hyaluronate injection, it will shrink automatically within 1 day of time.
Okay,
That is, we have tried so many times,
okay.
and yes, sir.
That's
single
what
tag
he is
also.
telling.
Yeah. Oh, man.
Yeah, we'll see. 1 or 2 cases we'll observe.
But your intention is to not this temporary.
Yes, sir. Not temporary.
Follow-up is also good with you?
That is to hanging. That hanging will be there.
Follow-up also is.
Yeah. Yes, ma'am. Yes, ma'am.
Okay. No, yes, a follow-up is there.
Yes, yes, ma'am. We can.
We try and see that.
You just try and have the thing, ma'am. Yeah. Thank you.
But they are fibrotic, how can they reduce? There are two types actually, firm fibrotic and soft variety of skin tags. Soft variety of skin tags can reduce with Hylis, what doctor said. But fibrotic variety, I don't think so, sir.
Supple skin tags also will be there.
Yes, there is a classification actually for skin tags.
Skin tags, yes. Classification is there. Temporary effect.
Thank you.